So today we'll discuss about intrauterine growth retardation. Now, this term is now referred to as intrauterine growth restriction. Synonyms for IUGR. Older terms used were chronic placental insufficiency, small for gestational age. Term used at present day, intrauterine growth restriction.
Or abbreviated as IUGR.
IUGR. The most widely used definition for IUGR: birth weight below 10th percentile for gestational age in the community concerned. Use two standard deviations from the mean values of birth weight to determine the percentile range. Birth percentiles vary from community to community. The terms IUGR and small for gestational age have been used synonymously in medical literature, but there exists small differences between the two. Small for gestational age definition is based on the cross-sectional evaluation, either prenatal or postnatal, and this term has been used for those neonates whose birth weight is less than the 10th percentile for that particular gestational age, or two standard deviations below the population norms on the growth charts. And the definition considers only the birth weight without any consideration of the intrauterine growth and physical characteristics at birth. An intrauterine growth restriction fetus is a clinical definition and applies to neonates born with clinical features of malnutrition and in utero growth retardation, irrespective of their birth weight percentile. Henceforth, appropriate for gestational age, infants can be labeled as IUGR if they have features of in utero growth retardation and malnutrition at the time of birth. Okay.
So we have to be careful on using SGA in lieu of IUGR, right? Because SGA refers to small for gestational age, appropriate for gestational age, and large for gestational age. But IUGR is a specific subset of these small babies that are specifically restricted in certain ways. Okay.
Incidence: 10 to 20% of all pregnancies. Perinatal mortality is 3 to 10 fold higher than in unrestricted developed fetuses. History: the term IUGR was first used in 1947, later modified in 1960, and greater attention was brought to this condition in 1980. In 1947, McBurney reported a group of infants with a gestational age of 38 weeks and over whose birth weight was below 2.5 kgs. He insisted that these infants were not premature and commented on the high incidence of complications in this group. These observations remained dormant until 1960, and then the syndrome was described in detail. Since then, a great deal of interest has arisen about IUGR and the complications such as perinatal asphyxia, meconium aspiration, hypoglycemia, and hypothermia, which are associated with this condition. It is now clear that there is an optimal range of size at birth, the range being between the 10th and the 90th percentile of birth weight in the region-specific population appropriate for gestational age. It becomes necessary to plot an intrauterine growth chart for each community and population, taking the birth weight of a large group of neonates against the weeks of gestation to allow the range of expected weights for each week, as birth weight ranges vary from one community to another.
So it's very important before we start going around diagnosing IUGR that whatever we're comparing it to are numbers that are not from some research study in some other part of the world, but it has to be region specific, even community specific.
Community.
How often do you think this is overlooked?
Very often I feel this is overlooked.
So we probably miss a lot of, well, we'll get there, but we probably miss a lot of symmetrical growth restricted fetuses then, because we're not identifying them early. Right? Asymmetric growth restriction is easy to identify, right? But symmetric is difficult to identify if we don't have a proper bell curve with fetal weights. So how do we go about getting the data? Is the question. How do we gather the information? From on the Government of India website, we can get it. Birth weights for a community. We have to do our own
Study.
All right, let's talk about fetal growth in utero.
In utero, this occurs in 3 phases. First 12 weeks, cellular hyperplasia, when the cells rapidly replicate in number. From 14 to 20 weeks, hyperplasia and hypertrophy occur, with cells rapidly replicating in number and size. And after 20 weeks, with only cellular hypertrophy being the dominant mode of fetal growth. Growth restriction can occur during any phase. Types of IUGR: symmetrical, asymmetrical, and mixed IUGR. Symmetrical, the least common type, 33%. Interference with growth occurs in the initial phase up to 14 weeks. All organs affected, including the brain. Changes are irreversible. Poorer prognosis. Potential causes: chromosomal, malnourishment, and or maternal infections. Asymmetrical, most common, 2/3 of cases. Interference after 20 weeks during hypertrophic phase. Most likely causes placental insufficiency. Clinically evident only in the 3rd trimester. Organs affected symmetrically.
Asymmetrical.
Organs affected asymmetrically. Brain sparing effect. Preventable and reversible, hence of interest.
Do you want to talk more about the brain sparing effect? What is the brain sparing effect in asymmetrical IUGR?
The brain cells won't be reduced, and
the body protects the brain's development, protects the brain's growth, and diverts any other nutrients from the rest of the body to the brain.
To the brain.
Right, because the brain is the most important organ in the body.
Correct.
The body knows that.
Mixed, more common in developing countries. Infants will have both a smaller number of cells and smaller size. Neonates have clinical features of both symmetrical and asymmetrical IUGR. Result of a neonate affected by early IUGR and also by placental causes later in pregnancy. That means initially there will be reduced number of cells, and then the placental insufficiency.
Cells aren't growing. The reduced number of cells they do have are still not growing.
Etiology of asymmetrical IUGR: chronic placental insufficiency, inadequate nutrients and oxygen due to maternal pulmonary disease and or anemia. Causes of chronic placental insufficiency include pregnancy-induced hypertension because of generalized vasospasm. Blood flow to the placenta is restricted. Then chronic renal disease, diabetes, chronic hypertension, post-term pregnancy, multiple pregnancy, previous small for gestational age baby, or history of unexplained fetal loss, antiphospholipid antibody syndrome, smoking, drinking, and pan, betel, areca chewing, maternal collagen vascular disease. Maternal risk factors for IUGR: Maternal age less than 16 years and more than 35 years. High altitude and maternal hypoxia, low socioeconomic status, and developing countries. Ethnicity or race. Maternal substance abuse, that is smoking, both active and passive.
Which means secondhand smoke can also cause it.
Alcohol, illicit drug like marijuana or cocaine. Maternal medication, warfarin, steroids, anticonvulsants, antineoplastic, and metabolites and folic acid antagonists. Moderate to heavy physical work. Maternal pre-pregnancy height and weight less than 20, weight less than 45 kgs and more than 75 kgs. Parity, none and more than 5 births. Interpregnancy interval less than 6 months or 120 months or more. Previous delivery of SGA fetus, small for gestational age, newborn. Assisted reproductive technologies. Pregnancy poor medical care. Pregnancy severe maternal starvation. Pregnancy poor weight gain. Maternal bronchial asthma.
And any congenital heart diseases that the mom might have that reduces the oxygen supply in the blood.
Maternal bronchial asthma, cyanotic heart disease, hematologic and immunologic disorders, acquired thrombophilias such as anticardiolipin antibodies and lupus anticoagulant. Maternal medical disorders, hypertensive disorders, gestational and non-gestational. Diabetes associated with vasculopathy, chronic renal disease, systemic lupus erythematosus, antiphospholipid syndrome, sickle cell disease.
Sickle cell is not very common in India at all. Nobody has sickle cell.
No, 1 minute, put it down. Poor medical, what is it?
Poor medical care. We mentioned that. Poor prenatal care, right? Lack of prenatal care can result in a severely restricted IUGR fetus, no? If she's not being appropriately followed. Okay.
And hematologic and immunologic disorders.
We already
Acquired, finished, no. Maternal medical disorders like hypertensive disorders, gestational and non-gestational, diabetes associated with vasculopathy, chronic renal disease, systemic lupus erythematosus, antiphospholipid syndrome, sickle cell disease. Pathological conditions in pregnancy like preeclampsia and diabetes associated with vasculopathy, maternal infection and parasite infections, torch, malaria, tuberculosis, urinary tract infections, and bacterial vaginosis. Placental causes for intrauterine growth restriction, placental weight less than 350 grams, abnormal uteroplacental vasculature, placental dysfunction, pregnancy-induced hypertension, preeclampsia, thrombophilia, related uteroplacental pathology, confined placental mosaicism, avascular villi, decidual or spiral artery arteriitis, multiple infarctions, partial molar pregnancy, syncytial knots, chronic inflammatory lesions, single umbilical artery, abruptio placentae, velamentous cord. You know what is velamentous cord?
Yeah, the insertion site is
Intermembrane.
yeah,
In the
it
membrane.
looks like a jellyfish almost. Yeah. I've seen a few filamentous
I've
cords.
seen one. Placental hemangioma.
I've never seen a placental hemangioma. Have you?
I don't remember.
It's
One,
like a
I
blo-
think,
is it like a blood polyp inside the
yeah,
placenta?
I think I've seen one. Placental infections, placental malaria, infectious villitis, multiple gestation, chronic villitis, chorionic villitis, or of unknown etiology.
Or reduced expressions in enzyme for redox regulation. But in 25% of cases, there's no observable cause.
No observed cause.
So that means 25% of the time is not preventable if we can't predict the cause.
Fetal adaptation to chronic plasma insufficiency, interference with blood flow that results in inadequate oxygen and decreased nutrients, fetus adapting to conserve energy to avoid hypoxia through decreased growth. So it will decrease its growth and will adjust to hypoxia. Decreased fetal activity, fetal movements reduced and all, and blood diversion to the brain sparing effect. So blood is diverted to the brain. Other organs will suffer, of course, but the brain sparing effect is noticed in asymmetrical IUGR.
Right. Which, when I picture malnourished children under 5, there's also the brain sparing effect for malnourished children. Malnourished children typically have the larger head, smaller bodies.
Determination of gestational is pertinent to accurately diagnose IUGR. Methods of determining dating and IUGR. Accurate history, LMP, examination of by fundal height. Fundal height increases by 0.9 centimeters per week at 24 weeks. Fundus is at the umbilicus, and after 24 weeks, the fundal height matches the gestational age, meaning that is at 32 weeks, fundal height should be 32 centimeters plus or minus 2 centimeters. Early ultrasound what is it?
So in order to get accurate dating, an early ultrasound, first trimester ultrasound with crown rump length is pretty accurate.
Accurate, only plus or minus 4.7 days.
And
Femur length and biparietal diameter from second trimester dating is accurate to plus or minus 7 to 10 days. Third trimester serial BPD and femur length to determine gestational age, accurate plus or minus 21 days. That is 3 weeks difference. If we do third trimester ultrasound, then we want to give the gestational age on that, plus or minus 3 weeks.
Right, so it can be harder to diagnose IUGR of unknown dating in the third trimester.
Early determination of the expected date is the most accurate form of pregnancy dating. Antepartum detection of IUGR. First, we must discuss the history of well-being,
Fetal well-being.
of fetal well-being in obstetrics. Prenatal care, maternal-focused care, started in 1892 in Paris and in India in 1930, and fetal antenatal care started in 1958. People started showing more concern about the well-being of the fetus at this point. This is when the fetus was recognized as a patient and fetal well-being tests were introduced in 1970. Neonatal mortality rate is lowest in Sweden, 1.7 per thousand live births. But in India, the neonatal mortality rate is still high. 1998, the neonatal
NMR, neonatal mortality rate,
was 53 in 1,000 live births, and In present day, it is now 19%, 19 per thousand live births. The goal is that appropriate fetal surveillance can further reduce the neonatal mortality rate. Fetal surveillance includes neonatal and intrapartum surveillance of the fetus, with the expectation that appropriate measures will be taken to promote the well-being of a compromised fetus. Antepartum detection of IUGR, clinical, ultrasound and cardiotocography, Doppler velocimetry, clinical.
So let's talk about each one of these options.
Clinical, maternal weight gain less than 0.5 grams per week,
Kilograms.
kilograms, sorry, and in the second and third trimester, and or less than 1.5 to 2.5 kgs per month. Symphysis pubis to fundal height measurement less than 0.9 centimeter per week as a
pattern, right? We're not going to expect IUGR in somebody whose fundal heights have been fine, and then 1 week it's off, right? We'd expect, the next time they come back it's normalized. If it's not, or it's, deviated further, then we can suspect IUGR, right? Because fundal height's a pattern. Fundal height pattern. Each person has their own kind of fundal height curve. It should match up with what we spoke about. The gestational weeks after 24 weeks should match the gestational age, right? The fundal height in centimeters should match the gestational age.
Age in weeks. After 30 weeks, suspect IUGR if there are significant fundal height discrepancies. If the fetal growth has a discrepancy of less than 4 weeks, mild IUGR can be suspected. If fetal growth has a discrepancy of 6 weeks, then suspect severe IUGR. Clinical estimation of fetal head in IUGR, fetal head is smaller and harder, fetal trunk smaller, liquor reduced because fetal urine is decreased, uterine tone irritable due to decreased blood flow and nutrient supply. This can lead to the uterus becoming more sensitive and reactive, resulting in increased uterine activity, contractions. The uterus contracts to try and improve blood flow and nutrient exchange. This can also lead to discomfort and perceived irritability. Daily fetal movement count. Fetal movement stop 12 to 48 hours prior to stoppage of fetal heart rate. Movement should be a minimum of 10 in 12 hours. Meconium aspiration syndrome. If only 3 movements noted in 12 hours, escalate to Doppler studies, and NST, immediate delivery may be indicated. Advantage of this clinical measurement is that it's easy and reliable.
But sometimes it's difficult for mothers to conceptualize the fetal movement count, right? Because it's usually not that the baby's not moving, it's that maternal perception is distorted, right? But this is the number one reason we have middle of the night moms coming in over concerns, right?
Advantage of the clinical assessment is that it's easy and reliable. In high-risk pregnancy with chronic placental insufficiency discovered through clinical findings, when to start using ultrasound for screening detection of IUGR. Make this a separate para. When to start? No, this should come down.
Okay. Keep reading. We're on screen. Keep reading. Keep going.
First ultrasound should be ideally done in the first trimester, but definitely before 26 weeks. From 28 weeks, every 4 weeks until birth. If IUGR is suspected, scan every 2 weeks.
Pause for a second. So we're saying in high-risk pregnancy with chronic placental insufficiency discovered through clinical findings, we'll do this ultrasound. But how chronic placental insufficiency always results in IUGR? Yes.
When the blood flow is diminished, it
always results in IUGR.
It will, if not significant, at least to some extent it may.
So, okay. Here you know. What kind of parameters do we assess with ultrasound?
Parameters which we consider are, first is crown rump length. No, crown rump length first.
Crown rump length is only in the first trimester.
First trimester, yeah.
So the parameters we look at in ultrasounds assessing for intrauterine growth restriction include BPD, the bipyramidal diameter, HC or the head circumference, AC or the abdominal circumference, and FL or the femur length. The bipyramidal diameter growth curve.
Two parameters. Late flattening of the curve is noted in asymmetrical IUGR.
So what happens is it's curving, and then it kind of plateaus at the end.
We better put a picture there.
Okay, keep going.
IUGR and a low profile curve pattern in symmetrical IUGR.
So in symmetrical IUGR, the pattern just slow.
Both those graphs you put here.
Slow.
Understand?
Yes, I understand. Okay, keep going. In normal pregnancy, the BPD increases by 2 millimeters per week until 36 weeks, and then 1.4 millimeters per week after 36 weeks.
False is not useful in diagnosing asymmetrical IUGR. Helpful only in symmetrical IUGR.
Because why? The bipyramidal diameter is the skull. An asymmetrical IUGR has skull brain sparing, so the head's going to keep growing, right? So, in other cases, what other parameters do we look at?
The abdominal circumference is most sensitive in diagnosis of IUGR. Ratios to be considered are head circumference over abdominal circumference and femur length over abdominal circumference are reliable for diagnosis of symmetrical IUGR. Femur length over abdominal circumference is more accurate than head circumference over abdominal circumference. It detects all asymmetrical IUGR. But accurate gestational age must be known. In normal pregnancy, femur length over abdominal circumference into 100 is equal to 22 plus or minus 2. In IUGR, it is more than 24. This ratio is most useful when gestational age is uncertain.
And other ultrasound parameters include the amniotic fluid volume, or the AFI,
placental grading, composite age widely used, estimate fetal weight, and Doppler velocimetry.
What does it mean by composite age with placental grading? Do you know? Look it up. Composite
age.
No, it's just guessing the age of the placenta. It refers to the overall placental maturity or the combined assessment of placental maturity relative to gestational age. Because accelerated maturity can lead to placental insufficiency. An extra mature placenta isn't going to be as efficient in nutrient transfer. Okay. So, besides ultrasound, what other technologies are used to assess fetal health in utero?
Of course, biophysical profile also needs ultrasound, antenatal NST.
Let's discuss biophysical profile.
We left something. Did we leave something?
Nope.
No, Doppler velocity we talked.
We're going to talk about it more after. We're talking about it more. Okay. So, biophysical profile, only to be done after 36 weeks. It was started in 1980, but prior to 1980, NST and the oxytocin contraction test, or the OCT, were more frequently used. Okay. The biophysical profile combines data from two sources, one dynamic ultrasound imaging and two fetal heart monitoring with real-time beam mode. The biophysical profile is a non-invasive test that predicts the presence or absence of fetal asphyxia and ultimately the risk of fetal death in the antenatal period. When the biophysical profile identifies a compromised fetus, measures can be taken to intervene before progressive metabolic acidosis leads to fetal death. Originally described by Manning and colleagues, the BPP has become a standard tool for antenatal fetal surveillance. There's two types of biophysical profile. One is the modified biophysical profile, which only includes an NST and AFI. And if either of these components are considered abnormal, then a full BPP is done only then. And we'll discuss those components later. To be clear, oligohydramnios is defined as an AFI less than 5, and polyhydramnios is defined as an AFI less than or greater than 24. And in IUGR, which is more common, oligo or polyhydramnios? Oligohydramnios only. But polyhydramnios is also abnormal, so we have to take that into consideration. Okay, tell us about the parameters of the full BPP.
These integrates 5 parameters. 5 components are fetal body movements, 3 movements in 30 minutes. Then amniotic fluid volume, AFI between 5 to 24. That's normal, I think.
Right, we're talking about, so we expect there to be at least, so these are the normal parameters. The fetal body movement is 3 movements in 30 minutes. That's what we expect. If there's not 3 movements, then it's a problem.
Amniotic fluid volume 5 to 24. NST reactive and non-reactive. Fetal tone. Does the baby have one flexion and extension? Movement of the arm, leg, and hands in 30 minutes.
So for fetal
at least
tone,
one.
Just one. Movements, we need 3, but fetal tone, just 1.
Breathing movements, 1 in 30 minutes.
So breathing movements are when we see the chest expand, right?
Hiccups are considered breathing activity. Each ultrasound assessment is graded either 0 or 2 points. If the variable is absent or abnormal, a score of 0 is given. If the variable is normal or present, a score of 2 is given. A biophysical profile is usually not performed before second half of pregnancy since fetal breathing movements do not occur before this. Score of 8 to 10 is normal, 6 equivocal, less than 4 abnormal. Observation time is 30 minutes. However, if all ultrasound variables are normal, the NST variable may be excluded because no change is made in the predictive accuracy of the biophysical profile by including the fetal heart rate. If one or more ultrasound variables is abnormal, the NST should be performed.
But you believe that even if all the parameters are normal on ultrasound components of the BPP, and NST should still be used. It's helpful to have as much information as possible.
Non-stress test. It is non-stress, so it doesn't. It's not an invasive
Right,
procedure.
it's not invasive. It's easy.
NST measures FHR, fetal movement, and uterine activity. Two FHR accelerations of 15 beats or for 15 seconds must be noted in a 20-minute reading. This will suggest that the fetus is well in utero for 1 week. Again, we have to repeat every week.
And the BPP, how often do we repeat? Weekly as well.
Weekly and some high-risk bi-weekly. Non-reactive NSTs, when the criteria are not met, suggest fetal jeopardy. High false positives and false negatives, less than 1 in 1000. NST measures the fetal reserve and indicates an intact autonomic nervous system. Fetus with decreased metabolic reserve exhibits a general lassitude of the autonomic nervous system and consequently fails to manifest accelerations of the heart rate with motion. Gita. Fibroacoustic stimulation test, started in 1984, has advantages over NST.
But there's mixed evidence about that. Fibroacoustic stimulation isn't used as an isolated test anymore.
If initial 50-minute NST reading is non-reactive, ensure the fetus is not in sleep cycle by having the mother take coffee or juice and change of position, or play music, talk to the fetus.
And continue for another 10 or so minutes, 5 or 10 minutes, right?
Okay. Doppler studies in IUGR. Umbilical artery flow studies are pertinent to the diagnosis of surveillance of placental sufficiency and subsequent IUGR of fetus. Other tests of fetal well-being do not accurately detect placental insufficiency. Doppler studies follow a longitudinal trend in the AV circulation of the fetus as well as the placental vasculature guiding management decisions regarding appropriate timing of delivery. Placental insufficiency is the most common cause of IUGR, growth restriction, and PIH, and therefore its identification is pertinent to improving perinatal well-being, and early detection is necessary in order to prevent further consequences.
I can't hear it in your hand. It's above your mouth.
Further consequences. Uterine artery Doppler has an important role to play in detecting the development of IUGR and PIH as early as 20 to 24 weeks. Adding Doppler studies to standard antepartum testing can reduce perinatal death rates by nearly 30%. I like this Doppler. Current research supports initially assessing the Doppler flow at the free-flowing cord site, meaning not either insertion end. Middle cerebral and umbilical arteries are the best for assessment of Doppler. These indicate the occurrence of redistribution of blood flow in growth-restricted fetus. Close monitoring and intervention is indicated in order to prevent a poor outcome in those fetuses at risk. In the past, the focus has been to reduce the neonatal mortality and morbidity with IUGR at birth. However, recent studies have documented adverse long-term neurological sequelae even with short-term exposure to hypoxia. Accurate Doppler flow studies can prevent even transient exposure to hypoxia. Role of Doppler has shifted from a curative to a preventive measure with truly informed and meaningful brain-oriented fetal care becoming a clinical reality. However, there are uncertainties that exist regarding the relationship between Doppler changes and the metabolic situation of the fetus. Therefore, more information may be needed to identify the optimal time of delivery to prevent any sequelae from occurring. Venous changes can appear in the severely compromised fetus if adequate measures are not taken. Very close-up follow-up, abnormal blood flow changes can be reversed with certain treatment modalities. If placental insufficiency is discovered prior to development of IUGR in the fetus. Color Doppler technology has provided the first non-invasive hemodynamic monitoring in pregnancy. There is ample evidence that Doppler incidences for the fetal circulation can reliably predict adverse neonatal outcome in a growth-restricted pregnancy. Serial Doppler flow studies can be recommended for those pregnancies for whose pregnancy has demonstrated placental insufficiency, early signs of IUGR, or those who are determined to have a high risk for fetal developing IUGR. Umbilical artery Doppler reveals changes of hypoxia at least 1 week before an NST or BPP can. It is the gold standard in the management of growth-restricted fetus.
So it's important to note here that in a Doppler flow study, the results can be normal uterine artery flow, absent uterine artery flow, or reversed uterine artery flow, right? And which one of those is the most severe?
Reversed, of course, is most severe.
Oh, they don't know.
But middle cerebral artery is very important.
Looking at the flow in the blood in the head.
This uterine artery is because for pregnancy-induced hypertension.
Well, now though, when I see people doing Doppler flow studies, they're not looking at the skull artery; they're looking at the umbilical artery.
Umbilical artery.
Okay.
NST, AFI, and Doppler studies are not competitive. They are simply complementary. The aim of fetal medicine today is to prevent the mere occurrence of IUGR in high-risk pregnancies through controlled maternal condition and adequate antenatal care, and deliver the fetus already affected with growth restriction before they suffer from effects of hypoxia. Complications of IUGR. Antenatal intrauterine death can occur during labor, fresh stillbirth, hypoxia aggravated resulting in meconium passage, and potential meconium aspiration syndrome. Neonatal problems are hypothermia, hypoglycemia, hypocalcemia, polycythemia. Antepartum therapy of IUGR. Control the maternal condition, that is well-controlled malnourishment, diabetes, hypertension, and maternal and renal disease. Bed rest in left lateral position. What's it now may not be recommended?
Now we don't typically recommend exaggerated bed rest for IUGR. But if a woman is laying, we want her to lay on her left side.
But
she can get out of bed.
No, but left lateral position has definitely improved.
I looked at some recent research studies, and
they did a study.
Recently, they did a bigger study, and they said that the size of the fetus and in relation to the woman's sleeping position was not correlated. But maybe for people who are already diagnosed pre-existing IUGR, if this is the only option we have, of course, it's an easy intervention, right? Having them sleep on their left side. But for the entire population of pregnant women, the sleeping position and the baby's growth or well-being were not directly correlated anymore. There was a big study in the 80s that said there was, but recently they did a study in the 2010s that debunked that study.
I don't agree because we did a study.
Well, you have one population here. I'm reading a study that has a larger
But
population.
that definitely because the races are different, castes are, communities are different. So naturally differences.
So your study at Kim's is one specific study to the population.
Yeah,
at
but in
Kim's.
that, there also I found left lateral position very important.
For your population at Kim's may be the case. But that
Yeah.
can't be correlated to the rest of the
No,
population.
but that rest population, if we do a study, maybe we may get.
So antepartum therapy also includes nutritional support, like oral and parenteral. Like maybe they'll need IV nutritional support. Amino acids I've seen given a lot, no? And pharmacological agents like aspirin. But the efficacy of that's in question, right? They used to
That
say
also we studied. Aspirin doesn't have any of this thing.
Right. But also aspirin's a relatively benign intervention, right? And so if it could help maybe 5% of cases.
No, that's why I never used aspirin.
But the rest of the world is potentially using aspirin.
No, multicentric study also had confused pictures.
Right.
So that's not
But during
recommended.
COVID, they recommended because COVID can
COVID
really,
causes blood clotting, no? So they recommended.
right. And so blood clotting in the placenta can be a reason for chronic placental insufficiency.
Yeah, that is during COVID because that is
So that begs the question, maybe with other infections, it could potentially help. If it could help 5% of cases, and aspirin has little side effects for people.
No, aspirin had definite side effects. That also we gave the dissertation topic to my PG, and bleeding, abruptio placenta, where incidence was little high.
All right. What are the indications for delivery or safe confinement for a baby with IUGR?
Uncontrolled metal condition, severe IUGR, fetal jeopardy, fetal maturity if it is attained, then also we should remove from adverse environment.
Right. So I guess one thing for IUGR babies we want to make sure we do prophylactically is steroids. Right? If we're thinking we're going to have to deliver an IUGR baby early because their
No,
growth,
but their lung maturity would have occurred in IUGR because they are subjected to stress, no, in
Right,
utero. So lung maturity, this thing, what you asked, you told.
well, in asymmetric IUGR, we discussed that there's a brain sparing effect, right?
No, but what did you say just now?
So if there's a 32-week fetus who has severe IUGR and we're contemplating delivery, we should probably give that mom steroids.
No, steroids are not helpful because already they're subjected to stress in utero, IUGR. So lung maturity would have occurred.
But in asymmetric IUGR, blood is shunted from unnecessary organs and given to the brain. So I would argue that the lungs are underdeveloped. Let's look it up.
In all my practice, I didn't use.
Well, that's your one practice clinical choice. The rest of the world abides
No,
by
that also
steroids.
multicentric study I've studied.
In your practice, Dr. Hirmath, we have to think about the entire
The
world.
entire multicentric, I've read lots. So after reading lots, I will just tell.
IUGR, baby's lungs.
And harmful effects are there with aspirin.
There's harmful effects to everything.
No.
So intrauterine growth restrictions decreases pulmonary alveolar and causes pulmonary artery endothelial cell dysfunction in vitro. But this is in baby sheep. I don't know why the article came up about sheep. Okay, so, well that's SGA. Maybe there's no full study.
I've read that multicentric study.
From what year?
Of course, during my.
So 20 years ago.
But now nobody did. Nobody has even time to do or patience to do. Now nobody does such mental studies.
So I'm not saying for IUGR babies that go full term, do we need to give steroids? But if we're contemplating delivery between 28 and 32 weeks for an IUGR baby, that's it would be more beneficial.
No, it doesn't help. You won't get a definite answer
I
for
know,
this.
everything says something different.
No, for this I know because I've read a lot.
But why?
I means aspirin, as such, aspirin doesn't
Not
have.
aspirin. We're talking about steroids.
Oh, steroids, steroids because that's what, no, lung maturity, the stress will cause release of lecithin sphingomyelin, steroids.
In intrauterine steroids, it releases the stress.
Stress
Stress
also.
response releases intrauterine steroids, so they already get their own small dose from the mom's body, so they don't need extra steroids because they're receiving it internally. Is what you're saying?
Because already they would have had.
But do you think that's actually put into practice? I mean, that makes sense. That makes sense physiologically. But when a doctor is talking to a patient and saying we'll have to deliver your baby at 32 weeks, they're not thinking about the fetus already gave itself its own steroids. They're thinking we'll just give the patient everything to try to make sure the baby's okay. Right? Steroids, magnesium sulfate for neuroprotection, blah, 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 blah. They give it everything. They throw everything. Right? The art of medicine is lost a little bit. Because then if the baby comes out and has poor lung function, the question is, what if we would have given this? So what to do? I think nowadays doctors just, even
I've seen people simply giving steroids.
you know, one patient came in at 36 weeks and she was in labor. The doctor said, should we give steroids? 36 weeks? No.
Then I in labor, that too. That's what.
Okay.
The steroids have been used in lots, but not with definite reasons. Just that things go on giving steroids.
Okay. So, what is the prognosis for IUGR infants, neonates?
Prognosis depends on type of IUGR. In IUGR babies, intellectual development is affected. Fetal growth, neurological, intellectual development, all are affected.
So
in severe IUGR.
not just the growth at birth, the continued growth of the fetus through childhood into adulthood. I don't know. I wonder if there's any studies.
Yeah, that also is affected.
Okay, so we have some images here. Restricted growth, small / less weight, constitutional effects, family genetic, just meant to be, you say, just meant to be a small baby. The other is intrinsic factors. This is for symmetrical growth restriction, right? Structural chromosomal infection, they cannot grow. They simply cannot grow, right? Extrinsic nutritional. So this maybe is more related to asymmetrical or no?
No, this is symmetrical.
Fails to achieve potential.
Symmetrical.
This is symmetrical only. There's constitutional, intrinsic, and extrinsic factors. Okay. Not allowed. Okay. So we know that there's genetic factors.
Why Brianna is standing there?
That's not Brianna. Genetic factors, placental factors.
Call me if you become pregnant. I will come and diagnose.
Well, I'm not gonna have an IGR baby because I eat plenty of food.
No, what you eat is not.
I know, I'm teasing. Genetic factors, placental factors, fetal factors, and maternal factors can all contribute to IUGR. Okay, this is my favorite picture. Clinical examination findings of the neonate with IUGR. Absence of buccal fat, right? So they have an old wrinkly face. Poor breast bud formation, right? Usually there's some fat on the breast buds. Okay. Thin umbilical cord. It's Wharton's jelly is not juicy. It's very dull looking. Relatively large and thin hands and legs compared to the body. Loose fold of skin in the nape of the neck, like a baby monkey, no? Axillar, interscapular area, and groins. Large head and large and wide anterior fontanelle. Anxious and hyper alert infant. Long fingernails. Loose, dry, and easy peelable skin. Small scaphoid abdomen. Poor skeletal muscle mass and subcutaneous fat. With thin arms and legs. So at birth, the immediate effects could be asphyxia, retinopathy of prematurity, hypothermia, hypoglycemia, or hyperglycemia, hypocalcemia, polycythemia, and hyperviscosity of blood. Intrauterine fetal death, low serum ferritin or anemia, pulmonary hemorrhage, immunodeficiency, renal dysfunction, feed intolerance or necrotizing enterocolitis, meconium aspiration, and persistent pulmonary hypertension. You know, I just read about a baby born at home and where I'm from who died of pulmonary hypertension 2 days after being born for PPHN. Isn't that sad? In America, a well-developed country, with
What happened?
the baby died of PPHN. The baby died of persistent pulmonary hypertension.
Oh, persistent.
Okay, so these are serious things, right? That's why early detection and appropriate treatment or appropriate, what am I trying to say? Planning is important. Okay, in conclusion, Dr. Hirmath, what?
Perinatal mortality has reduced from 30 per thousand, that was in 1969, to less than 8.7 now in advanced countries. Even less, I feel, because I don't know the recent figures.
Do you think it's less?
Today you see.
Okay, you keep reading.
With the to less than 8.7 now in advanced countries with modern technologies of antenatal fetal surveillance, Doppler studies, and biophysical profile, and with intense continuous intrapartum monitoring, electronic fetal monitoring, scalp pH in rare cases, timely delivery, and extended cesarean section, survival has increased also due to tertiary neonatal care. To date, there are no effective treatment improvements which improve the growth pattern of the fetus. Potential therapies currently utilized are maternal nutrition supplement, plasma volume expansion, and amino acids, and other maternal medications like aspirin. Although none have proven to have a large impact on sustaining fetal growth and are used as maintenance therapies and not curative. The development of a good placental circulation is essential for the achievement of a normal pregnancy. To facilitate this, we must encourage women to make lifestyle changes well before conception.
Any last facts about IUGR?
I can't understand your facts.
Any more fun facts?
Fun facts. I can't understand your fun facts.
Fun fact, like IUGR babies look like old little grandpas.
Wise old look.
Yeah.
They're very ugly. I don't know when they grow up how they become.
They're kind of ugly. I wonder their hormonal systems are also underdeveloped, no? Are they more likely to have HPO axis disorders? Thyroid disorders? I guess it depends on where in maturity. It'd be interesting to look at a study if the initial insult of chronic placental insufficiency happens.
At which period of gestation?
Yeah, what's more likely to occur. But chronic placental insufficiency is rarely an acute event. No, I mean, abruptio placenta is obviously an acute event. But the other types of things that cause chronic placental insufficiency are chronic insults over time, right? So difficult to know. Yeah. Have you dissected a lot of placentas that were IUGR placentas?
But of course, we didn't have any macroscopic study, no? Only grossly we used to study every case.
Well, we should look at it microscopically.
Microscopy, but we can't understand, no?
We need a pathologist.
Pathologists. And they also, I don't believe, because they may not give correct interpretation.
Can't trust anyone.
So I can't
never trust the pathologist.
because I don't think, because it is studying under the microscope is eye straining. So I don't know how accurately they will do.
Oh, you think that all pathologists go cross-eyed, they can't see clearly.
Then
Anything else you want to add?
no.
Okay. Thank you.
Thank you, Brianna.